Okay, let us start the next sessions for today. Today we are lucky to have with us Prof. Dr. Shanmuga Sundaram from Kerala, India, to give us a talk on role of SPECT-CT for parathyroid imaging. For those who has attended his sentinel lymph nodes workshop back in 2019, I'm quite sure that he has left quite clear remarks on his ability to guide us and explore new knowledge. Prof. Dr. Shanmuga is a clinical professor and the head of Department of Nuclear Medicine and Molecular Imaging at Amrita Institute of Medical Science in Cochin, Kerala since January 2000. He became a diplomat of the National Board of Examinations, New Delhi in Nuclear Medicine in 1997 and became a fellow of Asian's Nuclear Medicine Board in 2015. He is a member of National Academy of Medical Science and was awarded the EACV1 certifications in cardiovascular imaging and nuclear cardiology by European Society of Cardiology back in 2019. Dr. Sundaram did his nuclear cardiology fellowship in UCLA, USA, hybrid imaging fellowship in Catherine's Hospital, Germany in 2004, PET-CT imaging and diagnostic fellowships in Peter MacCallum Cancer Center in Melbourne in 2010, and PET-MRI fellowships at Mayo Clinics, USA in 2017. So Prof. Sundaram has published over 140 national and international publications and regularly provides lectures in multiple national and international conferences. He successfully started the DNB in nuclear medicine course in 2006 and the first MD nuclear medicine course in India under MCI in 2011 at Amrita Institute under his leadership. The institute was the first to offer PET-CT back in 2009 to the people of Kerala and became the first university hospital in India to have a PET-MRI services in 2018. Without further ado, let's give Prof a pause and invite him to give us the lecture.
So we shall be discussing the general concepts on hyperparathyroidism, its impact in the SPECT and planar imaging of hyperparathyroidism. We shall be seeing why technetium systemae dual phase parathyroid scintigraphy planar imaging is the main workhorse of parathyroid imaging. What will be the impact of SPECT-CT in day-to-day practice? How to perform a SPECT-CT? How to interpret a SPECT-CT? Also, the emerging role of choline PET-CT. We do routinely the SPECT-CT and also for some specific patients where we are always getting the conventional system-AB scan negative, but there is a high clinical chance to have hyperparathyroidism. We do 18F labeled choline PET-CT also. I will also be introducing you to a very new, excellent concept, minimally invasive radio-guided surgery, which we routinely do in the last 12 years. So we know the incidence of hyperparathyroidism is significant. It is 1 in 1,000. Majority of the time, the culprit is parathyroid adenomas, more than 80% of the time. 20% of the time, it will be hyperplasias. We know very well, hyperplasias are a bit difficult to be imaged and it is a diagnostic challenge. Majority of the time, hyperparathyroidism patients are asymptomatic. They are picked up during the routine investigation for hypocalcemia. Hypocalcemia is a common issue. Patients have severe body pain and they go for a calcium test. And instead of hypocalcemia, what we pick up is hypercalcemia. And those are the patients who are completely asymptomatic towards hyperparathyroidism. As the main management of hyperparathyroidism is by surgery, more than 95% of patients will need surgical cure. It is imperative to have a pre-operative imaging. So that's where the nuclear medicine plays an important role. Just to recap the anatomy and embryology of parathyroids, it is very important for us to recap, as the imaging by nuclear medicine techniques depend a lot on this. We know that there are 4 in numbers, the normal parathyroid glands, and it is important to understand that they are very, very small lesions. As they weigh only 60 milligram, normal parathyroids are never imaged, and any abnormal uptake, any uptake in parathyroid region of system EB is to be considered as abnormal. As it is developing from dorsal endoderm of 4th and 3rd pharyngeal pouches, especially the inferior, they are notorious to be seen in ectopic positions. Majority of the time, as it migrates along with thymus, you can see it in mediastinum, and they are relatively more variable in position when compared to superior glands. As high as 20% of population, it can be ectopic. So obviously, our imaging has to cover the neck and also the chest, the mediastinum. Another important thing, parathyroids have chief cells which secrete parathormone, which is the main culprit in hyperparathyroidism. But interestingly, our interest is not towards the chief cells, but the oxyphilic cells. Why oxyphilic cells are very important? Oxyphilic cells are very important because they are rich in mitochondria. As they are rich in mitochondria, you are going to have a significantly high or higher system EB uptake in oxyphilic cells. Parathormone controls the calcium homeostasis. It has actions on bone resorption. Kidneys, it increases the calcium reabsorption, and also it increases the small bowel absorption of calcium. So the hyperparathyroidism can be primary. Most of the time, the culprit is the adenomas. Secondary, it is due to the chronic renal disease where there is a diffuse hyperplasia of the parathyroid glands, and it can become tertiary when it becomes autonomous. So it is easy to image the primary hyperparathyroidism, tertiary hyperparathyroidism, because what we image is adenomas. But in secondary hyperparathyroidism, you have hyperplasias, which is a diagnostic challenge. So let us go through some of the established nuclear medicine procedures. The imaging of parathyroid started with a subtraction image, where you take a thallium image, you subtract the technetium uptake in thyroid, thereby the abnormal thallium retention in the parathyroid is considered to be parathyroid adenomas. But it is very technically challenging. Patient's cooperation is very much needed. That's where the system EB came into picture, and this is a guy, Thalifer is a nuclear medicine doctor who was just as a resident in Canada, established and standardized with the double face technique. So double face technique is a planar image. You take the neck and anterior chest image during the first initial time, immediately after the injection, then 2 hours delayed, dual face technique. There is another subtraction which is very important, is technetium system EB per technetate subtraction scan. This is reserved for two specific areas. One is for the rapidly washing out adenomas, which can be missed in a conventional dual phase technique. And also when you have associated thyroid pathologies like solitary nodules or multinodular goiter, you will prefer technetium system B, technetium pertechnetate subtraction scan. So it is to be highlighted that majority of the time we start with technetium system B dual phase technique or double phase technique, where you take a planar initial delayed image. If this scan becomes negative and if you have associated thyroid pathology suspicion, or if you have suspicion of rapidly washing out adenomas, then the next day we do a technetium system B pertechnetate subtraction scan. So there are many factors which influence the adenoma uptake. Its size, position, so the higher the size or the larger the size, possibly it is easier to be picked up. Position, ectopic positions are difficult to be picked up on a planar image. The higher the number of oxyphilic cells, even though the size of the gland is small or size of the adenoma is small, you are going to have easy uptake of system B and a higher sensitivity. On the other hand, if you have expression of P glycoprotein in the adenomatous cells, then you are going to have lesser system B uptake. It is easy to understand when the cells are in hyperplastic, that is when they are in active growth phase, S1 phase, then the chance of these cells being picked up by system B study is higher. On the other hand, the multiglandular disease can be missed, meaning the higher the uptake or the highest uptake adenoma only may be picked up. So these are some of the points which influence the system B uptake. Coming to the special technical parameters which has to be kept in our mind. Number one, which is the tracer you are going to prefer? We always almost prefer technetium system B. That is because technetium system B uptake is proportional to the mitochondrial membrane potential. The higher the number of mitochondria, the higher the system B uptake. On the other hand, tetraphosphine is just a difference in the cell membrane potential, and all studies, including our own experience, have established system B as the radiopharmaceutical of choice. Coming to the collimator, you always prefer parallel hole collimator, high resolution collimator. If you have older gamma cameras, you can go for a pinhole collimator. Coming to the techniques, yes, we always start with planar imaging. After the planar imaging, it is almost every time we do a SPECT-CT because it has higher sensitivity. We will be seeing in subsequent slides why it is having higher sensitivity. So what are the advantages of a system B scan? It is non-invasive. It has a higher sensitivity. You can image both the neck and the mediastinum, and for post-operative recurrence also it can be used. But when the deeper adenomas are there, or when it is in ectopic positions, especially in tracheoesophageal groove or in carotid sheath in neck or behind the thymus, then you need. So we also have some pitfalls. What are the pitfalls? The technetium system B scan can be falsely negative in rapidly washing out adenomas. It can be negative in some of the multiglandular disease. It has a lower sensitivity in hyperplasias. You can have localization errors, especially in planar imaging, and you can actually have false positive studies if you have solitary nodules, multinodular goiter in thyroid, or if the lymph node pathologies, non-specific lymph node positivity by system B also can contribute towards the false positivities. So what are the indications for SPECT-CT? So to take care of the pitfalls of planar imaging, we come with SPECT-CT techniques, and these are the established indications for SPECT-CT. So whenever you suspect there will be ectopic parathyroid adenoma, whenever you are suspecting multiglandular pathology like in tertiary hyperparathyroidism, whenever you suspect there is associated thyroid nodule, or if the patient is presenting post-operatively again recurrence, the SPECT-CT is imperative and it becomes part of our day-to-day practice of Sesame B planar parathyroid imaging. So along with the planar, you must do a SPECT-CT in all these clinical indications. So how to perform this study? The technical parameters. We have to use always a 128 matrix so that the image quality becomes better. You always acquire 360-degree acquisition. You will have more projections, especially if you have dual head gamma cameras, you can give 3 degree per projection. The imaging must be done at least 20 to 25 seconds per frame. Then only your count statistics will be good. Coming to the CT component, you don't really need to do a contrast study. You just need a non-contrast localization CT. It will be very interesting to understand whether you have a 2.5 MA, 30 MA, 40 MA or up to 80 MA. Any type of SPECT-CT equipment will be relevant in parathyroid imaging. Ideally, you do it with 30 to 40 MA X-ray. So if you have a GE, you will have 30 to 40 MA SPECT-CT. If you have Siemens, then you will have 40 to 80 MA also. So because of the presence of good softwares today, the radiation exposure to the patients are brought down, but you should take 2.5 millimeter slice. Reconstruction should be 2.5 mm in the CT. Also, technically, you should know when to do a SPECT-CT. Ideally, you can do a dual phase. That means you will be doing SPECT-CT twice during the imaging of initial and also delayed. So when you will prefer, when the planar scan is negative, when you know that the previous planar scan is negative, then you will be doing a dual phase, meaning the SPECT-CT will be done both during initial and delayed scan. But the lesion is already localized in the planar image. You want to know exact anatomical site, then you will do a single phase. But most of the time, because we don't know whether the patient is having positive or negative scan, you will end up doing a dual phase SPECT-CT. So compare the sensitivity of SPECT-CT towards planar. This is the details from the literature and also our experience. Majority of the time, you will not be missing out the parathyroid adenomas if you do a SPECT-CT, 95% sensitivity. So what are the advantages? Why should we be doing a SPECT-CT? Obviously, even a small lesion of 0.6 centimeter to 80 milligram, not gram, it is 80 milligram, you will be able to pick up the small adenomas. Whenever your planar imaging is negative or a conventional ultrasound is negative, it has an incremental value. Having told that, what are the disadvantages of SPECT-CT? Relative radiation exposure to the patient is higher with SPECT-CT, but still it is lesser when compared to a 4-dimensional 4D CT. Why I am mentioning 4D CT? Because 4D CT is the next line of imaging for the identification of parathyroid adenomas if the nuclear scan is negative. So we get around 22 millisievert compared to 11 millisievert when you do a SPECT-CT when compared to planar scan. But still it is acceptable because of the higher sensitivity. So when you interpret, how to interpret a SPECT-CT, you have to keep it in your mind. The superior parathyroid glands are posteromedial aspect of thyroid at the level of cricoid cartilage. So these are very basic images. These images are obtained with 2.5 MA Infinia Hawkeye, and even in that you will be able to make out which is the cricoid cartilage, which is the tracheal region. And why we should be seeing this is the superior parathyroid gland means the ectopic positions can be tracheoesophageal groove. It can be retroesophageal, back to the esophagus, posterior to the esophagus. It can be intrathyroidal or it can be in the pharyngeal spaces. So you should know what you are actually looking. So in superior parathyroid gland, you have to look for its site, and also if it is not there, then look forward for the ectopic positions. On the other hand, in inferior parathyroid glands, you are looking at the inferior pole of the thyroid gland, and if it is not there, then look for the ectopic positions. This is much more challenging when compared to superior parathyroid glands. It can be in the true sheath of thymus, it can be intrathyroidal, it can be in anterior mediastinum, it can be in submandibular location, it can also be in retroesophageal and carotid sheath and tracheoesophageal grooves. Three important sites. One is carotid sheath. You have to look in tracheoesophageal region. Majority of the time you will be picking up, and the other one is anterior mediastinum. Submandibular location is very rare. So always you should know what to look in the SPECT-CT. So I'm going to show some interesting images to convince you why you should be doing a SPECT-CT and what are the information you can get it from that. So this is a patient. You know that this study seems to be positive. You have taken an initial image, a delayed 1 hour. I will tell you why I took a delayed 1 hour. Normally, I would have taken a delayed scan, but this is a known case of multinodular goiter. So you are going to have some associated thyroid pathology. Patient's parathormone is very high. So you are looking for a parathyroid adenoma, and the SPECT-CT helps you to exactly identify this as a left upper parathyroid adenoma. So in the planar scan, yes, you are seeing some uptake in the left upper, but with the SPECT-CT, you are more sure. So this is for the exact anatomical location this SPECT-CT was done. So the second one is a 10-minute initial image, a 2-hour delayed image. You are not able to really pick up the parathyroid adenoma. There is still retention of tracer in the thyroid bed. On the other hand, in the SPECT-CT, you are able to clearly localize this to left inferior parathyroid adenoma. Again, anatomical location in suspected rapidly washing out parathyroid adenomas. Why it is not seen? Because it has completely washed out from the abnormal site, and what is the normal uptake in the thyroid gland or thyroid bed only you are seeing in this. So whenever you have a doubt whether we are really dealing with a parathyroid gland or parathyroid pathology, a SPECT-CT will be useful. So this is a patient who is not really having a clear-cut symptomatic or biochemical hyperparathyroidism. Why? Because it is just relatively higher. The parathormone level is around 126 up to 65 to 75 is the normal, and patient is asymptomatic. You are clearly able to see it in the planar scan, and exact localization is possible here from the SPECT-CT. So this is to show whenever you have a parathyroid gland in the planar imaging, you need not even do a SPECT-CT as long as you are very confident that this is the parathyroid adenoma and also its location. So this is again another interesting case to show even a small lesion as small as 4 millimeter lesion, the exact anatomical site can be assessed by the SPECT-CT. So this is a very interesting case. This is tertiary hyperparathyroidism, known case of chronic kidney disease. See the parathormone, it is 2737. that gives clearly an idea that it is a multi-glandular pathology. So in the planar scan, you are able to see upper uptake. You are not clear or you are not sure about its exact localization, whether it is superior or inferior. And also you are seeing something in the mediastinum. So this is where the SPECT-CT helps. It clearly localizes this to the left mid-pole thyroid planar uptake, to the exactly to the superior parathyroid on the left side, and this mediastinal uptake, you are very clear that it is in the anterior mediastinum. So it gives a lot of ideas and lot of information to the surgeon how to plan the imaging and also how to plan the surgery in these patients without further imaging of this patient. So this is another interesting case where you are able to make out there is some extension of the left inferior in the thyroid bed. You have some doubt, but the uptake is not very significant. But in the SPECT-CT, you are able to show the uptake. So not only for the localization, but also for the exact whether the real lesion is there or not, sensitivity is improved. So in our day-to-day practice, this will be really relevant to you. What you have to do in all patients, are we going to do all scans? Not really. You start with a ultrasound, and after the ultrasound, you go for the double phase scintigraphy. If it is negative, then go for the subtraction scan, and finally you go for a choline imaging if the SPECT-CT is also negative. So these are some of the choline images, again to show that we don't do for all patients, but when you have perfectly normal study or when you are not able to show the parathyroid glands, here the parathyroid conventional system EB scan is negative. So you went for a choline scan, see the anatomical resolution of the PET-CT and also the uptake pattern, left upper parathyroid adenoma. So the same thing can be done in PET-MR also. So we have the good fortune of doing this in PET-MR also. So this is a very low suspicion. Serum PTH is only 100 picogram, but still the parathyroid adenoma is picked up on the choline scan. So the last part of our discussion, something very exciting, minimally invasive radio guided surgery, what it is and how it is to be done. So this is normally done for virgin cases where you have not done surgery, or when it is a recurrence, you will be doing this. But before doing that, you have to ensure that the system EB scan is positive, and on the day of surgery, you will be re-injecting the patient with system EB. The surgery is done along with the quick PTH assay also. What is the advantage? You have a 97% success rate. The mean operating time is only around 40 minutes. Our patient comes as an outpatient and goes as an outpatient. It has a very good success rate in previously operated patients also. How it is done? So this is an interesting person. He is a 27-year-old male who is a television actor. He gives a history of hemithyroidectomy 10 years before at the age of 17 itself. And now he has all the typical symptoms of hyperparathyroidism, bone pain, and now a system EB scan clearly shows that there is a recurrence of the lesion that is in the right inferior parathyroid adenoma. Possibly he had a left hemithyroidectomy. So this is how this MIRS is done, minimally invasive radio guided surgery. The patient will be injected with system EB on the day of surgery, 2 millicurie to 3 millicurie. And using a cordless gamma probe. This is a cordless gamma probe which we have, very small, very compact. Any gamma probe can be used and it will clearly show where exactly. You will operate it just with a 2 centimeter to 3 centimeter incision. You will expose it using the gamma finder and you will be removing it. Once you are removing it, you will be able to ex vivo count it. Once the count rate is clearly showing that this is the pathology, you can close it. and you can see how small is the scar. So this is the biggest advantage of minimally invasive radio guided surgery. So we have done more than 100 to 200 cases in the last 12 years, and in our day-to-day practice, we realized that the mean operating time has significantly decreased in these patients, and the surgical completeness of these patients also is very good. So what we have discussed, what we have learned in the last 30 minutes, nuclear medicine imaging is an integral part in the parathyroid localization. Almost always we will be doing a planar scan, but we know now what will be the impact of SPECT-CT, who are the patients to undergo a SPECT-CT. We should selectively use subtraction techniques and SPECT-CT in our day-to-day practice. MIRS is a very, very good technique. I think it should be popularized in your country. I am there. Whenever you call, I will come back to show how it is to be done. Thank you very much for your patient hearing. So whom I am showing here is, you know, Dr. Abdul Kalam. He is our president. We had the good fortune of him coming to our institute, inaugurating our PET-CT. He is my guru also. He is Dr. R.D. Lele. He has won the highest civilian honor in India, Padma Bhushan, and with whom only I learned a little bit of nuclear medicine from him. And also Abdul Kalam, he is a good friend of us. We have interacted with him when he was the professor of IIT, Indian Institute of Technology in Chennai. Thank you very much once again for your patient listening. Thank you.
Thank you very much, Prof. Shanmuga. I'm sure that there are a lot of burning questions in your mind, but keep it to yourself till our questions and answering sessions. We will therefore proceed next to the next speaker. Our next speaker is none other than someone we have known, Dr. Siti Zarina. Dr. Siti Zarina is the current National Head of Service for Nuclear Medicine at Ministry of Health of Malaysia, and she is also the Head of Department of the Nuclear Medicine Department in Hospital Kuala Lumpur. She graduated with MBBS from University of Malaya and later obtained the Master of Medicine in Internal Medicine from University of Malaya back in 2005. She completed her fellowships in nuclear medicine at Brescia, Italy in 2011. Dr. Zarina has presented in numerous national and international conferences and has published multiple articles in peer-reviewed journals. He was the former president of Malaysia Societies of Nuclear Medicine and Molecular Imaging. Without further ado, let's invite him to present the next talk. Thank you.
Thank you, Mr. Chairman, Dr. Chen Siu. Comparing to my CVs with Prof. Sundaram, I feel so little, but we are catching up. Okay, so actually, I would like to welcome everyone here. It's a great pleasure to be in this conference. I think with all the sponsors here, it is really a great opportunity when they are sitting together with us. Usually they're outside, but now you have the opportunity to see them and they are able to listen to what we usually talk about. Okay, so I'm given the task to talk about the incremental value of SPECT-CT in differentiated thyroid carcinoma. It's more of a local experience. I think, sorry. Okay. So basically, among the MOH hospital, HKL was the first hospital to have SPECT-CT. It was in 2014. So since I am going to share my experience about using SPECT-CT in managing DTC patient, I would like to show what happened before we have our first SPECT-CT. We have our SPECT-CT in HKL somewhere in 2014, and there's one patient that really make us really want to fight to have a SPECT-CT. It occurs somewhere in 2011, as you can see in this image. There's a 40-year-old gentleman, he's a surgeon. He had a total thyroidectomy done in March 2010. and it shows a widely invasive microfollicular carcinoma of the right thyroid lobe with lymph node metastases. So he came to us for a second radioiodine therapy somewhere in 2011, and it was shown to be physiological. So with that, the TG level is a bit on the high side, which is more than 300. At that time, our TG monitoring also is not as good as current situation. So what happened is that we actually proceed patient with FDG PET-CT. It was available in Putrajaya at that time. And from the FDG PET-CT, it is also physiological, but we only see a bit of sclerotic lesion on the left ileum. So left sacroiliac region. What happened during that time? We proceed with bone scan. And as we know, the sensitivity of bone scan for detecting thyroid bone metastasis is not that good. What happened about 2 years later, after second dose of radioiodine, 100 MCI, as you can see here. Chen, go back. Okay, all right. As you can see here, the disease become more progressive. There's uptake in the skull, and there's something here which might more prominent posteriorly, and we think that is at the sacroiliac region, but on the other side instead of left ileum. So we need to know what are we going to do to this patient, because he's very young, very energetic and productive. So we actually have a tough time sending patient to get an appointment for CT scan, where finally we know that from here, actually there's a very mild uptake here in the midline, more prominent posteriorly. So finally, we managed to see in the CT, there is actually a lytic lesion at the T3 vertebra. And what happened to the uptake in the skull? We thought it's in the skull, it's a bone metastasis. But when we did MRI, it is actually metastatic deposit at the meninges. So it totally changed the management of the patient. Instead of just treating as bone metastasis, we are able to send patient to see a neurosurgeon, and they have removed the meninges uptake, and they actually did a surgery for him, and also radiotherapy. Unfortunately, this patient did not make it. He developed a very progressive disease involving the lungs. So now I come to the topic why we need a SPECT-CT. So introduction, in patients undergoing radioiodine, whole body scan has been an essential imaging modality for the completion of staging, risk stratification, assessment of residual disease, therapeutic planning, as well as to detect recurrence. However, we know that planar WBS whole body scan gives a 2D nature, which it cannot provide depth information about the disease, and there is lack or poor anatomic information because of the poor image resolution. So in 2004, I think we have heard it yesterday during the officiating when Dr. Ng officiated this conference. We know that second generation of SPECT-CT was introduced in 2004, and since then we have a first evidence on the clinical value of SPECT-CT in DTC, which was published under Thub and co-workers. He reported that a 57 increment in diagnostic accuracy of iodine 131 SPECT-CT compared with the planar imaging in a group of 71 patients. And as we know, after 2004, a lot of studies has appeared, and majority of the evidence available has addressed the potential of iodine 131 SPECT-CT in patients studied at radioiodine ablation. All right, we don't know so much. I mean, there are papers regarding pre-ablation and also on follow-up. And in a majority, it shows a diagnostic accuracy which varies between 31 and almost 50% of patients. So we know that advantages of SPECT-CT images over planar whole body scan have been reported in the management of DTC because there is a precise localization and it is able to characterize the abnormal foci of radioiodine accumulation seen in SPECT-CT images, which lead in changes of staging, risk stratification, and also management. At the same time, it increased our confidence in reading the image. Because of the CT-based attenuation correction, it definitely improved the image quality. So when a lot of studies also initially look at the value of SPECT-CT in the neck for DTC. And as you can see here, SPECT-CT allows a precise localization and easier differentiation of benign radioiodine uptake in the remnant thyroid tissue from malignant radioiodine accumulation in metastatic cervical lymph nodes or distant metastasis. And iodine SPECT-CT reduces the equivocal findings frequently accounted on planar imaging. So based on this, okay, there's something there, okay. So based on this, we can see that there is incremental value of SPECT-CT, about 41% compared to planar imaging, differentiating thyroid remnant and also thyroglossal duct. So, you know, when we do SPECT-CT in indeterminate neck lesions, which we see on planar scans, we restudy with SPECT-CT and you can reclassify it as thyroid remnants, lymph nodes, metastasis, radioiodine contamination, oropharyngeal secretions, or physiological variants. And there is a value of SPECT-CT even though that we did actually send patient for ultrasound, which say that it is normal lymph nodes, but with iodine SPECT-CT, it improved that it is actually a disease. So there's a role of SPECT-CT in the cases where even though ultrasound mentioned there's lymph nodes, but we should consider doing SPECT-CT. Now, how about HKL experience? We do have a lot of cases, but I'm glad that we have one study looking at 78 patients and doing a SPECT-CT in the neck region. It was detected about 91 radioiodine foci in the neck region, and we analyzed the area comparing planar as well as SPECT-CT, noted that the lesion-based analysis, iodine whole body planar scan yield diagnostic information in 83 patients, but when we do SPECT-CT, you can see that the diagnostic information increased to 96.7%. And it has changed the diagnosis in about 33% of patients. So this is very important. So when 3 patients you do a whole body scan, you can actually detect more information in one of the patient. So on patient-based analysis, from the planar, it has altered the planar findings in about 37.2% of patients when we do SPECT-CT. So there is risk stratification group and clinical staging according to the NM classification were revised about 10.2%. And definitely from this study, it shows that SPECT-CT significantly altered the personalized treatment planning for each DTC patient. Okay, this is an image of a patient where you can see that this is a normal oropharyngeal uptake and stomach uptake and intestinal uptake, but there's uptake in the neck and also a very subtle or mild uptake, slightly lower rate. When we did SPECT-CT, we can see that it is actually the remnant of the thyroid tissue, and maybe you can see it clearly here, there is actually a thymus uptake. Now, another example, iodine SPECT-CT carried out in a woman with multifocal papillary thyroid cancer. Initially, the staging is PT1B, N0, and MX, stage 1. So classified as low risk, but when we did the planar whole body scan, there are 2 foci of uptake in the neck. So we need to differentiate whether this is actually remnants, lymph nodes, or something else. So true enough, when we do the SPECT-CT, as you can see here, the first one with the longer arrow, it is actually a lymph nodes metastasis. And if you, I don't know whether you guys can see here, there is actually some hypodense area in the lymph nodes itself. And the second uptake, slightly higher up, with this short arrow, you can't really see a structure or tissue over there. And it turned out to be thyroglossal duct remnant tissue. And I think after this image, we restage a patient and patient become a T1A and 1B and reclassified as intermediate risk. So, when we reclassify as intermediate risk, definitely the management of iodine to the patient is different. In low risk, yes, you can escape by not giving this patient any thyroid, any radioiodine. But the moment it becomes intermediate risk, we should consider giving radioiodine. All right, Barber et al. Has shown that thyroglossal tract thyroid tissue was to be reported in 47% of patients, and it could be accurately characterized on post-therapy SPECT-CT. And the tissue is not usually removed during total thyroidectomy, and it can create a diagnostic uncertainty on post-surgical TSH-stimulated planar radioiodine scans. SPECT-CT can confidently confirm that uptake in the neck is benign in nature, preventing misinterpretation of findings as metastatic disease. I think we really have a bad experience regarding this. Even thyrotoxicosis patient also, you can really have a persistent uptake of the thyroglossal cyst, more so in a patient who had total thyroidectomy. And if you keep on giving radioiodine, it is actually meant for a benign disease, which I think SPECT-CT really helps in differentiating the diagnosis. How about using SPECT-CT in DTC with metastases? We know that SPECT-CT can be used to localize early skeletal metastases, as well as mets in the lungs and also mediastinal lymph nodes. Q and colleagues reported that iodine-131 SPECT-CT exhibited significantly higher sensitivity than TC99M MBP bone scans in depicting thyroid cancer metastases. This is an example of a patient who has multiple metastases of the bone. As you can see here, there is uptake here in the neck, which actually from planar we can tell that this is more likely to be bone rather than the thyroid remnant. Why? Because it is more prominent posteriorly. And true enough, when we do a SPECT-CT, you can see that there's uptake at the C7 level with lytic changes on CT. You can see here, right? So there's lytic changes there. Next, we look at the uptake here. Roughly from whole body planar scan, we know that this is could be a pelvic bone uptake, which is true enough on SPECT-CT. You can see the uptake here and a lytic lesion in the superior iliac spine. Another uptake in the thorax, which could be ribs or lungs, but I think as a clinician, we have to relate everything. This is a bone and this is bone. Most likely this is in the ribs. Plus, the uptake is actually situated at the periphery rather in the lung field itself. But with SPECT-CT, it definitely confirmed our diagnosis of uptake in the ribs. Another image showing that expected uptake in the thyroid remnants, but at the same time, there's some uptake at the lower left thorax, more prominent posteriorly, and we did a SPECT-CT. We can't really see any lytic or whether this lytic lesion is really lytic or something else. True enough, biopsy was done. It turned out to be a fracture of the 12 ribs. So this is an example of uptake in the bone, but it turned out to be benign. So benign versus malignant in SPECT. How does SPECT-CT able to tell that? A study has shown that at least 22% of radioiodine scans will have a cryptic findings, including benign mimics of disease. And the majority of these normal variants are correctly identified on planar imaging, but SPECT-CT helps to resolve the diagnostic uncertainty and increase the confidence and accuracy in interpretation. Savas et al. Shows that 216 SPECT-CT scans and found out that oral radioiodine uptake was present in 57% and postulated that the radioiodine loved to go to this metals area via a semi-permanent chemical reaction. And other studies also have shown that SPECT-CT confirmed that 91% showed focal radioiodine localizing to dental restoration. So we had an experience where patient actually have a maxillary uptake and we have the opportunity to do SPECT-CT. If we don't have that, we might say that it is actually uptake in the oral because of the dental plug or whatever. But because of SPECT-CT, it turned out to be actually a solitary maxillary lesion. So it is really helpful to do SPECT-CT in those kind of patients. When we know that 90% of them will show focal radioiodine localizing to the dental restoration. Another scan where you can see that expected thyroid uptake again in the neck, but there is a very faint lesion somewhere in the liver and also down here. True enough, when we do SPECT-CT, it turned out to be a focus of calcified granuloma in the dome of the liver and also an exophytic cyst arising from the inferior pole of the liver, of the left kidney, sorry. Now another patient of ours, a lady, a 57-year-old woman, underwent completion of thyroidectomy and left modified radical neck dissection for follicular variant of papillary thyroid carcinoma, PT2N1. She was referred for radioiodine therapy. So after 12 weeks of surgery, and she was given 120 MCI of iodine. And her stimulated serum TG is less than 0.1, but the anti-TG is positive. So as you can see here, there is uptake somewhere in the skull area, expected uptake in the neck because of could be thyroid remnants, but there's something not right here. So we did a SPECT-CT. Actually, from whole body planar, you can roughly gauge that this is actually uptake in the bone posteriorly because it's more prominent, and true enough, actually it's in the bone. And the uptake in the abdomen turned out to be a very large mass, retroperitoneal mass. You can see that from CT, there are inhomogeneous hypodensities region, which did not take up iodine, when the rest of the mass actually take up iodine. So patient was referred to gynae team. The cancer antigen 99 and 125 is very high. And later on, they did a left self-finger oophorectomy, and it turned out to be another carcinoma or tumor, which is endometrial adenocarcinoma, mucin-rich variant. And they did a sampling, so which this could be due to ovarian cancer, which metastasis to the uterus, or endometrial cancer with left ovarian metastasis, or it could be a synchronous tumor. So what happened to patient? Patient was then started on neoadjuvant chemotherapy, which consists of carboplatin and plexitexel, followed by right self-finger oophorectomy and hysterectomy. So it shows how things change, and actually it helps patients a lot. Now, from literature, we know that ovarian uptake of iodine has been reported in the literature, which can either be benign or malignant. Benign could be because of the benign struma ovary, mucinous cystadenoma, serous cystadenoma, cystadenophibroma, endometrial cyst, leiomyoma, and mature cystic teratoma. So malignant causes, it could be granulosa, cell tumor, mucinous adeno-CA, and metastasis from the primary papillary thyroid cancer itself. But in that case, it turned out to be another malignant disease. So the exact mechanism of uptake of iodine, we don't know, but it was believed that because of the sodium iodide supporter expression that can occur in the uterus or ovary, and also because of the tumoral inflammation which results in increased vascularity and capillary permeability. So this case illustrates the importance of SPECT-CT in characterizing a non-physiologic iodine uptake on plana, which unmasked an undiagnosed gynecological malignancy. So another benign image, as you can see here, out of a sudden, this patient turned out to be physiological. There's no disease, but there's something in the oropharyngeal area or slightly above it, which likely could raise from the eye, and true enough, from the SPECT-CT, it is actually an uptake of lacrimal sac. We asked the primary team to further investigate, turned out to be MRI normal. Iodine can be taken up in the lacrimal duct or lacrimal sac, which is obstructed, or in this case, it's not. Another interesting uptake, as you can see here, physiological uptake, gastric uptake, but there's an uptake, a focal uptake here. So we did a SPECT-CT. It turned out to be a gallbladder with gallstone, showing that gallstone with cholecystitis. So we refer to surgeon for the gallstone. All right. So this is a case which we do. We did the SPECT-CT almost the whole body, because as you can see here, there's a very mild uptake here on the right part of the skull, turned out to be a lymph nodes. Another uptake in the middle of the neck, instead of thyroid remnant, it turned out to be a submental nodes. Another uptake also, a nodal mets here in the paratracheal region. At the same time, when we look at here, we already classified this uptake and midline uptake, but there's an uptake here which is more prominent posteriorly. True enough, we did a SPECT-CT of the lungs. It shows that uptake was in the lungs. But as you can see here, sometimes uptake in the lungs precedes the anatomical changes. You can't see any nodes, but there is actually uptake. And patient has a lung metastasis, which is actually improving. So as you can see, there's another uptake in this region, which is Y, inverted Y in shape. And true enough, it turned out to be uptake at the thymus. Later on, patient had 2 doses of iodine, and there's uptake only remains at the cervical nodes. There's not so much uptake in the lungs anymore, but there's suspicious foci actually in the pelvic region. So when we did a SPECT-CT, it turned out to be there's an uptake at the cervix part, at the cervix region, and referred to gynae. They did a sampling. It turned out to be non-malignant, and it is a nabothion cyst, which means that the skin trapped the mucin from the cervical gland. So what are the advantages of SPECT-CT? It is able to detect non-iodine avid lesion. Manges and colleagues has reported that CT component has the ability to identify non-iodine avid tumor, increasing the sensitivity from 62 to 74 and unchanged, with unchanged specificity, about 98%. And iodine 131 SPECT-CT depicted additional non-iodine avid disease in 21.6% of patients with an intermediate to high risk thyroid cancer recurrence. So as you can see here, there's an example of a patient. This is a 41-year-old lady with papillary thyroid carcinoma, showing a large lobulated soft tissue mass at the right thyroid bed with calcification within. However, the iodine uptake only occur at the medial part of the thyroid gland. So when this happens, patient has high TG, we refer patient for FDG PET. It turned out to be, there is FDG hypermetabolism in the large soft thyroid tissue mass. So as you can see here, meaning that the FDG or the part of the large soft tissue mass which is not taken up iodine has become de-differentiated. This is the example. You can compare again. Just a small part of the thyroid uptake in the thyroid gland as compared to the FDG uptake. So it definitely changed the management of patient, whether you need to consider radiotherapy or TKIs. So last but not least, there is a role of SPECT-CT in deriving a tumor dosimetry. In HKL, we don't have the opportunity to do so. Probably IKN has the chance to do it. But from there, the information obtained from imaging can be used to determine tumor dosimetry, particularly when high-dose iodine therapy is being considered. And SPECT-CT can be used to better define the volume of metastatic disease and thereby provide more accurate tumor dosimetry. So what is the impact of SPECT-CT on staging, management, and prognosis? Of course, post-therapy iodine SPECT-CT studies and follow-up diagnostic scans after thyroid remnant ablation have demonstrated improved characterization of nodal, as well as the M status on TNM staging. And at the first radio ablation post-therapy, SPECT-CT was found to restage the cervical and status in about 35% of patients. And as you can see here, more of SPECT-CT usage is to remain a high specificity in detecting thyroid recurrence. So the results of radioiodine SPECT-CT imaging leads to changes in clinical management that includes subsequent use of radioiodine, modification of the extent of surgery, the use of external beam radiation therapy, and the inclusion of alternative imaging procedures. This is a journal or a paper written by Sang Woo Lee in a Korean Society of Nuclear Medicine. So the author suggested that SPECT-CT can be used at different time points during the management of differentiated thyroid cancer. We can use it at the pre-ablation state, at the post-therapy period, which is commonly done, and also at the long-term follow-up period. And from all the readings and papers, the suggestion for clinical indication are inconclusive planar images, routine procedure at first ablation, including T1 tumor, including intermediate to high risk, and also including high serum TG levels. So I guess this is something that we can consider, especially at the routine procedure at first ablation. As I have shown earlier, the first slide, when we do it for all the uptake in the neck, it has shown an increase of or changes of patient's management. So in summary, advantages of SPECT-CT in DTC is actually to reduce the number of equivocal findings. It improves the imaging specificity, and it is able to detect metastatic disease without radioiodine concentration in some patients. And this leads to a change in staging, risk stratification, and patient management, and it can give a prognostic information concerning patients with DTC. Same like what has discussed earlier, we should know the limitations. It causes additional radiation exposure from the CT component, about 1 to 4 millisievert with each acquisition. It causes additional imaging time, and of course, it causes cost-related issues. So with that, I thank you.
Thank you, Zarina. So from the previous two speakers, we have seen that we can bring in life to the dead body and no longer seeing the ghostly image. We have pressure to have another speaker with us, Associate Prof. Dr. Subapriya, to talk about how to optimize the utility of CT imaging in the era of hybrid imaging. So learning to fuse the functional and the CT structural components from the hybrid imaging. With that, we would like to welcome Prof. Dr. Subapriya. Allow me to introduce Prof. Subapriya. Prof. Subapriya is a dual-trained nuclear medicine physician and clinical radiologist. She is a senior medical lecturer at UPM and is the head of nuclear imaging department at her institutions of teaching hospital. She is currently the vice president for the nuclear medicine wing of College of Radiology, Academy of Medicine, Malaysia. Dr. Subapriya is a council member of Malaysia Society of Nuclear Medicine and Molecular Imaging and head of research subgroup of the society. Her keen interest is in brain imaging, and this has led her to be the founder of the Malaysia Society of Neurocognitive Clinical and Behavioral Imaging. Along with her postgraduate students, she conducts research and various educational events under Neurocognitive Society and labs, and that are related to her research interests, which is the imaging of behavioral addictions and Alzheimer's disease diagnostic. She is a florid writer and has published more than 50 articles in index journals related to radiology and neuroimaging. With that, let's welcome her once again.
Thank you, Mr. Chairman, for your introduction. And I would like to thank the organizer, NCNM 2022, for inviting me to be part of this wonderful gathering. So today I'm talking about optimizing utility of CT. So previously we heard Dr. Muhammad Shahrir talking about the SPECT component. So I'll explain a bit about the CT component after this. And as you know, I'm actually a radiologist by training, and I had the honor to get trained by a lot of wonderful experts in the field of nuclear medicine. And now I'm proud to say I'm a nationally certified nuclear medicine physician. Thank you so much to all my teachers. I would like to acknowledge Dr. Siti Zarina, Dr. Ng Chen Siu, who were my main supervisors during my national subspecialty training in nuclear medicine. I also trained under Prof. Shoban Winjamuri at the Royal Liverpool and Broad Green University Hospitals in UK. So all this cumulative exposure has made me appreciate seeing previously maybe the corpse. Now I combine it, so give life to the corpse. Okay, so the ghosts and the corpse now are alive. And now I'm at Hospital Pengajar, University Putra Malaysia, heading the nuclear imaging unit there. And these are my team. We are actually a very small department. We started off in 2019. Our hospital is very new, and we had the first SPECT-CT installation in 2019. And ever since then, we are growing in strength, getting lots of referrals. So we are very happy to say that this is a good experience for my team and myself. So speaking about the SPECT-CT machine, it started off with a humble gamma camera, right? And then there was the CT scan lying across the big brother, and somehow somebody decided to marry these two together, right? Okay, which is not turning up, but this guy named Hasegawa in 1999 decided, why not we combine these two technology? And therefore, yes, he created the prototype of the SPECT-CT machine, and now we get the benefit of using it for our clinical practice, right? So these two machines have very different technologies, but with the advances in technology, they are now a hybrid machine. So let's talk about CT. Okay, what is a CT scan? It actually transmits X-rays. So there's a tube that generates the X-rays. It penetrates into the patient's body and is detected by detector rings, and then it is produced as an image on our monitor. And these X-rays are different from the gamma rays that come out from radio nuclides. So these are from the machine. It's generated and it transmitted into the patient's body. So there are different properties of these X-rays, and let's understand how they form an image. Okay, so we have to understand, like for functional imaging, we measure things like standardized uptake value, SUV. For CT scan, we measure Hounsfield units. So Hounsfield unit is using water as the denominator, and the mu is the linear attenuation coefficient that is measured in relation to water. And if water is 0, then we consider the densities of various other matters in our body. If they are positive or more dense, such as gray matter, white matter in the brain, or bone, they have a positive value. So the Hounsfield of water may be around 10 HU. For bone, it can go into thousands. Metal, it can be 3,000, 4,000 Hounsfield units. So this gives us an idea what is the composition of the structure we are looking at by measuring the HU in CT scan. Whereas for air, air is minus. It's very low in its linear attenuation coefficient. So it'd be like minus 1,000. If it's fat, it will be like minus 10 to minus 50, lower in attenuation. So we can determine sometimes the presence of fat may indicate a benign kind of condition. So it helps when we measure the Hounsfield unit on CT scan. Then we go on to how do we get various images in one CT imaging. Sometimes we look at the lung better, sometimes we look at the bone better, sometimes we look at the soft tissue better. So all this is done by windowing. We can adjust the window width and the window length to give us various images just by one examination. If we change the window width to 2000, window length to 500, we will get a bone window setting. These are presets, so with the advances in technology, like our industrial partners know, with just a click of a button, we can get that image, bone window setting. You see it in bone window. And similarly, if you want a lung window, you can go for windowing of window width 1500, but the window length will be minus. So we are able to see the air in the lungs. We can look at lung window. So I know the most concern why we do not use CT routinely in all our imaging is because of the radiation. That's one of the main concerns. But we have to weigh the pros and cons to justify the imaging so that we can give the best management for the patient. So CT abdomen may carry an effective dose of about 8 millisieverts, which is equivalent to half a year of background radiation. But it may carry a better prognosis for the patient to have their disease evaluated. So what are the other benefits of performing CT in hybrid imaging? The most common one is for the improved attenuation correction for improved image quality. Previously, radionuclide transmission measurements were using the transmission from the emissions from the radionuclide. However, now with the CT technology, it enables reconstructed images with quantification in terms of absolute units or some equivalent. This enables us to even reduce the duration of period a patient may be in the department. For example, previously, if we have a lot of bowel activity in a myocardial perfusion imaging, we have to ask the patient to eat and wait and repeat the scan. But now with improved attenuation correction, we do not need, even there's a lot of bowel activity at the inferior wall, we still get very good image quality and we can confidently let the patient go. Another benefit of using CT for hybrid imaging is for the image co-registration. This is a no-brainer. Yes, we have a functional and we have a structural image. We can see it in one image, giving us the best information for patient management. So this is definitely the most important function of hybrid imaging that we are all enjoying at the moment. Another benefit of CT in hybrid imaging is for quantification, which Dr. Fazrin has explained. At the moment, it's more of an academic kind of function. We do not use it routinely in all clinical practice, but it may be useful if you have a lesion and you want to quantify treatment response. You can actually measure the SUV using SPECT-CT. This is an example of bone SPECT-CT, and a few other speakers previously have expounded on the benefits of determining whether it's a malignant or a benign condition. Even Dr. from India, Dr. Shanmuga has mentioned if it's in the pedicles, it's more likely metastasis, but if it's in the facet joint, you're more confident to say this is degenerative changes. So as you can see this, oh, sorry. Yeah, here. It's in the facet joint, and you can see reduced joint space, irregular joint space, some air even like a vacuum phenomenon. So all these are more in favor of degenerative changes. So we can safely say this patient does not have evidence of bone metastasis in this bone scan. So me and my colleagues, we have done a systematic review on the role of bone SPECT-CT, and we have reviewed works, and we have determined that actually using SPECT-CT can increase the sensitivity and specificity of determining indeterminate bone lesions by 93% improved sensitivity and 96% improved specificity. And we have described, like how Dr. Shanmuga said, actually in many Asian countries, vertebral uptake is commonly TB in origin. We have to look at the patient's history, the pattern of the CT bone lesion. This is one of the reasons of high false positives in bone scans, which you have to keep in mind in Asian countries, which is endemic for TB. Also, we have to look at the other patterns, like if it involves pedicles, we are more confident of calling it metastasis. Also, apart from looking at the bone, we have to keep our mind open that sometimes we see abnormal uptake in extraskeletal regions. So having the SPECT-CT was really useful to localize where the abnormal uptakes were coming from. This patient actually had rhabdomyolysis, did a case report with Dr. Ng Chen Siu, where we identified this was like the primary team didn't even know the patient was actually having some renal impairment. He had undergone angiogram a few weeks prior, and because of the renal impairment, there was retention of the contrast in the body, which became toxic and caused rhabdomyolysis. If this patient was not referred by us identifying this acute condition, it would have been lethal. But with our identification of this, we referred, and patient underwent hemodialysis to clean the toxin from the body. So we have to bear in mind, SPECT-CT helps us to localize where actually the pathology is coming from. And this is an article in Press. We reviewed whether now with the advances in SPECT-CT technology, does it mean we don't need gamma cameras anymore? Do we do SPECT-CT for all patients? But as you know, everything is in moderation. We have to justify what patients would benefit, and also to improve patient throughput. We cannot afford to put every patient under SPECT-CT. So we still have to use our prudence to decide who needs to proceed with the SPECT-CT imaging. Right? And then I would like to talk about PET-CT, although it's a bit out of our SPECT-CT topic. In UPM since 2010, we've had a PET-CT scanner in our research institute, and we've performed many cases related to oncology, even cardiology using rubidium, and some nuclear neurology. And PET-CT is although it's the more advanced technology, it was the PET that was combined with the CT first, and SPECT was later. So PET is very well established as a hybrid imaging technology, and we know how useful it is in oncology imaging. And just want to share some updates about PET. Although we are very familiar with PET, there may be things that we can improve in further innovation, such as introducing contrast-enhanced PET-CT. I presented at the recent Asia Oceanic Congress of Nuclear Medicine and Biology in Kyoto recently, and the topic was, my topic was on the study I did with my postgraduate students, where we did evaluate the role of using contrast-enhanced PET-CT. Definitely, there will be some elevated SUV values when you use contrast for attenuation correction. We do not use the low-dose CT for attenuation correction, so that we can reduce the radiation dose. We just do a contrast-enhanced CT and then the PET and do fusion attenuation correction using the contrast-enhanced CT. And this enables a diagnostic scan and also a functional scan in one sitting. And we have to be aware that SUV can be about 10 to 20% higher than with low dose. But this is maybe pertinent in certain conditions where the patient will benefit from contrast-enhanced PET-CT. So these are the results of our study, where we compared it and looked at the liver SUV uptake based on various BMI categories. In the ideal BMI category, we do not see much variations, but they bear in mind if the extremes of BMI, you may see more variations when you measure SUV in the contrast-enhanced scans. And we published this finding about the reliability of using the SUV values in contrast-enhanced scans, and we hope that it can be a reference for future clinical practice. And among the clinical utility, of course, head and neck cancers would be very good a condition for contrast-enhanced scans because of all the small structures in the head and neck region, very less fat plane to differentiate structures. So this is very helpful to determine any soft tissue lesion that will actually be more apparent on a CT scan. Right here, more apparent, and you can determine that there is a lesion there, and also a lymph node that is necrotic that also shows uptake. So having a contrast-enhanced scan will be very useful. Sometimes lymph nodes are very small, adjacent to vessels. It's very easy to miss. And even in ovarian cancer, we have experience in doing contrast-enhanced scans, and this helps us to evaluate the bowels. We also give rectal contrast so that you know whether the ovarian tumor has invaded into the adjacent bowels or not. In peritoneal metastasis, it's very useful to look at it in a contrast-enhanced scan. Performing the contrast-enhanced scan helps to increase the accuracy for detection of liver lesions as well, up to 6 millimeter in size, from 63% to 90% when we use IV contrast media. And it also increased the accuracy of contrast-enhanced images as compared to non-contrast-enhanced images when we assess for infiltration of pelvic malignancies into the adjacent structures, such as bladder. So the usage of contrast media also helps us in either upstaging or downstaging, the TNM staging, such as lung cancer. It can help us to determine the nature of the lesion. So it's like a one-stop center imaging with a contrast-enhanced CT as well as a PET in one imaging. There are certain recommended CT protocols if you want to perform a contrast-enhanced PET-CT. You can scan the thorax first because thorax usually is in the arterial phase, followed by abdomen and pelvis, and then finally scan the head and neck. So these are some ways to optimize on the faces of the vessels when you perform a contrast-enhanced PET-CT. Lastly, we also need to bear in mind, we don't always need to use iodinated contrast media. We can also use negative CT contrast such as water. We can ask patient to ingest plain water to look at the pancreatic region better, small bowels. We can also infuse through the rectum to give a negative contrast in the large bowels, so we can be able to determine GIT lesions better. So in conclusion, hybrid imaging using CT technology helps in attenuation correction, improved disease localization, improved image resolution, and can help in quantification of a pathology. And points to be considered when we decide to use CT hybrid imaging with our functional imaging is there a need to actually add on this, or just leave it at the planar imaging? We still have a choice. The planar imaging is definitely not going to go away fully. And would adding contrast media be useful? And whether we want to use positive or negative contrast agent, and what protocol to use. With that, I would like to thank you.
Thank you very much, Dr. Subapriya. It's now the time that we give up with all the speakers, and if you have any questions in your mind, do bring up for discussion. With that, I would like to invite Prof. Shanmuga, Dr. Siti, Zarina, and Prof. Subapriya to be seated in front.
Both.
So let's start off with our questions and answering sessions. I would like to open up for the floor for any questions. Any questions that you would like to clarify from the speakers?
I have questions. I would like to ask Prof. Subapriya, when you did the study on SUV for with contrast, it increased about 20% of the lesions. What about the background? Because I've been told that, from the literature, that sometimes the reason that in lymphoma cases, we can give contrast, but we have to be careful because it's serial. And the other thing is that it actually reduces the target to background ratio. So from your study, does it say that the SUV of the lesion increased 20%? How about the background? Thank you.
Thank you for the question, Dr. Siti Zarina. So it's a pertinent question where we actually measured the SUV max in the liver, but we didn't measure in the mediastinum. Maybe future studies can measure the mediastinum, but the liver uptake is definitely higher. And so this will be like we have to then be alert. If we are using contrast enhanced scans, we still report, like, based on the Deauville criteria, whether it's higher than the liver or not. So I wouldn't say that it affects the tumor to background ratio, because you will then become familiarized with a new background. You know, the new background will be the new baseline setter. And so anything beyond that would then be pathological. So you base it on what is your denominator. So previously, if you're using non-contrast enhanced scans, maybe the SUV of the liver will be around 2.5 to 3 SUV max. But with the contrast, it can be like 3 to 4, let's say. So you will then get used to a higher baseline, but you would then base the lesion on a higher value. Is it higher than the liver? And then you base your Deauville criteria on that. Yeah.
So from that study, we didn't look at the SUV of the liver increment, because the lesion is 20%, whether the increment of the
it was the liver increase, also the 20%. Yes.
Actually, in day-to-day practice, it is important to understand that the SUV values are falsely higher if you do a contrast enhanced CT, true. How much percent we learned from Dr. Subapriya that it is around 20%. But what is very important in our day-to-day clinical practice is majority of the time, even though we are doing a follow-up scan, if we are doing again with contrast, the target to background ratio or the SUV values may not change much. So if there is a reduction, we know that it is a real reduction due to chemotherapy or any other intervention. Problem comes when we are following these patients with non-contrast CT. So that has to be kept in our mind. As we know already, the fact that SUV means it is highly variable, inter-observer variability, inter-institutional variability, inter-equipment variability, so many variabilities are there. So we need to keep it in our mind that if we are going to do a contrast enhanced CT, and when we are doing the follow-up also, majority of the time, especially in liver tumors, we do it as a contrast enhanced CT. So it should not affect too much, but it affects in lymphomas where the follow-up scan can be non-contrast, but that's where the semi-quantitative parameters dual score comes into play. So where you don't compare it with the previous scan, rather you are comparing it with the same studies, mediastinum as a background, liver as a second background. So obviously this correct utility of these quantitative parameters will help, and we need to keep it in our mind when we are reporting how significant is the SUV reduction. That's where the SUV reduction means always look for 50% reduction. Then you commit that it is a response. If it is less than 50% or lesser than 25%, be careful in reporting that. So these 3 points we should keep it in our mind.
Just one question. If the diagnosis is established as a lymphoma, is there any need to do in contrast CT?
That is a pertinent, perfect question, which I can expect from a senior doctor like you, because I know that this is not recommended. That's exactly I told that a follow-up study, especially in lymphoma, which is much more frequently done as an interim therapy and a completion therapy, you don't really need to do a contrast study. That's where you need to use quantitative parameters. Dual score is a must, because today medical oncologists not only depend on your SUV values and your findings, he looks for the dual score. If there is a reduction in the score by 1 or 2, then his aggressiveness in the therapy management also changes. So always use dual score in the lymphoma follow-up. And for your question, yes, definitely not really necessary to do a contrast CT every time, especially in lymphomas.
Thank you. Any more questions from the floor? There's one question on parathyroid scintigraphy. In our center in Johor Bahru, we are combining, of course, independently we have single isotope dual phase study or dual isotope subtraction study. And in our center, we combine up the two. What we did is we will do a thyroid parathyroid scan. Then a few minutes later, immediately we inject the sestamine, followed by a subtraction study. And later on, we continue to follow up 2 hours and 4 hours later. We try to combine the best of the two. Now, the question is, noted from your presentations that your centers tend to use solely on dual phase study. What is the comment on the difference on these two from your experience?
For that matter, even in India, majority of the centers or more than half of the centers may be doing the same procedure what you explained, mainly to avoid the second visit of the patient for a pure subtraction study. But I don't agree with that. I will substantiate why I believe a dual phase study is much more relevant. The sensitivity of dual phase parathyroid scan is more than 80% in adenoma scan. So the most important criteria to understand, to identify the presence of an adenoma is the delayed scan. In the delayed scan, if you are seeing a retention of tracer, retention of uptake in the superior or inferior pole of thyroid bed, then you are very sure. And that's where I personally feel doing a subtraction study will reduce the sensitivity. Let me explain why I feel like that. You are doing a pertechnetate scan to start with. When you are doing a pertechnetate scan, you have a pertechnetate uptake in the thyroid. Even though we are doing the study at 20th minute after the injection, the uptake of technetium, even though it is not organified but just trapped, will reduce, but still the background will be significantly high. The thyroid uptake will be always be there. So I personally feel the delayed retention of the uptake, especially in the upper or lower pole, or if there is an ectopic in the mid pole of the thyroid, you are missing it out. And majority of the time, more than 80% of the time, the dual phase is going to pick up. So I reserve the subtraction scan only for those 20% of patients where you are going to have a rapidly washing out adenoma. And this rapidly washing out adenoma is also taken care with the SPECT-CT. Because anyway, I'm doing almost in all of the patients, I do SPECT-CT as a routine. So because of this, I don't prefer to do a subtraction scan and the dual phase scan in one phase. Yes, it is very important to understand the presence of multinodular goiter or thyroid pathologies adding to our confusion. So because I use a dual phase plus SPECT-CT, I personally feel subtraction scan, let it be reserved only for those rapidly washing out adenomas, which is less than 10% in our day-to-day practice. And those 10% of patients has to take the trouble of coming the next day for a subtraction scan. And subtraction scan, patient compliance also is very important. You have to make the patient to lie down for 10 minutes after the injection or 15 minutes after the injection of pertechnetate. Then again, after the imaging, you are injecting sestamib. Again, you must wait for 10 minutes. You should not be starting the imaging immediately. So 10 minutes initial image. So total more than 30 minutes patient has to lie down without any motion. So let that difficulty of the lying down, let it be reserved for the 10 minutes. That's my concept and that's my understanding why I don't combine it. But I am not going to criticize you why you are doing it. But I personally feel the delayed imaging specificity goes down with the background uptake of pertechnetate because of this initial thyroid scan.
My follow-up to the Ernst patient just now, I noticed that in your presentation, when you show the images, you take 1 hour to 2 hours. And there are, images in which you take 1 hour and 3 hours. There are centers that are doing 2 hours and 4 hours. So which one is the best?
I think for clarity, for teaching purpose, I will suggest the initial image should be done between 10 to 15 minutes post injection. And the delayed scan, some people say it is 2 hours, some people say it is 4 hours. I think anything between 2 to 4 hours is fine. Why I am doing that 1 hour image? Probably as a intermediary between what we have discussed. That is to look for that rapidly washing out parathyroid adenoma also, and 1 hour delayed image I am doing. But for our discussion purpose, to make it simplified, I will suggest initial image 10 to 20 minutes, delayed image 2 to 4 hours. 1 hour only in patients where you are looking for thyroid associated pathologies or that initial image. You just do that. Otherwise, it is not really necessary. Yes, Dr. Priya.
Oh, hi, everyone. So I have a question to ask you. In the center that I'm practicing right now, we only have a planner and SPECT. So in a case where there is incompetent pathology parathyroid adenoma, if I were to use the only scan, is there any modification that I can do to differentiate between these two? Because I do understand that the tension in thyroid pathology is longer. So is there anything that I can do to include outside of Muslim.
Yeah, I fully understand. We were also at one time in 19, when we started our department, we had only a SPECT imaging. So that time, it is really tough to do a SPECT, especially after seeing a SPECT-CT, you don't feel like seeing only a SPECT. It is really tough. And my personal opinion is planar is good enough. If you are unable to do a SPECT-CT, I will prefer to do only planar because it is really difficult. So having told that, your question is very pertinent, and I will not be really able to add much to your difficulty, because as I accepted already, it is definitely tough. So the only technical difference, what can be done, can be the fact that the initial and delayed scan and initial and delayed SPECT, only that much we can do. Probably if you are having a platform, because majority of the vendors right now are giving a platform for you to fuse the CTs also. So if we can do a CT separately, we can fuse and we can see. Probably only that much I can add for that technical advantage. Otherwise, it is really tough. I fully accept. I think I answered that question. I will repeat it. So if you know by the planar scan already that there is some uptake, you want to localize it correctly, then do a single phase SPECT-CT to reduce our time or to save our time as a delayed scan. Or delayed here we mean by 1 hour. After 1 hour, you do only once a SPECT-CT. If you have already seen some uptake in the initial image, that it may be most probably your intuition is most probably it is going to be positive, then you can do that. But when you have already done a planar scan or somewhere else already, or we are repeating the study, we realize that it was a previously normal study, but clinically still we suspect there must be some presence of parathyroid pathology, then you do a initial and delayed. Timing after the initial imaging, you are injecting 20 minutes later, you are doing a planar scan is for 10 minutes. So 30th minute, you do the initial SPECT-CT. Then delayed scan at 2 hours, the planar scan is done, and 2.5 hours you are going to do, or 2 hours 15 minutes, you are going to do the delayed SPECT-CT. So if there is no uptake, or if there is a planar scan negative, you will do twice. If your initial scan shows some uptake, you will do only once at 1 hour. That is what is rapidly washing out parathyroid adenoma. So in that case, if you had done the SPECT-CT at 1 hour, you would have localized it to non-thyroidal uptake. So you know the fact that it is a parathyroid adenoma. So that is where the 1 hour delayed SPECT-CT is relevant.
Prof, I would like to ask regarding the contrast enhanced CT. So which patient you choose to go for contrast and which patient not to choose for contrast?
Are you
a bit fair, then you expect as a fat plane inside, then you don't need contrast. Or the skinny patient go for contrast. Is it like that?
You are talking with reference to parathyroid or PET-CT? Okay. My concept is slightly different from what is being discussed. I believe strongly we are having a PET-CT, and see the configuration of this equipment supplied by our vendors. It is 64 slice, 16 slice, 128 slice. So when you are having a so high-end CT with you, you should use it as a real contrast CT. You should try to give all the information that my radiology colleague can give. So we believe in reporting this as a PET findings and all diagnostic CT findings. So I strongly believe all patients, if they don't have any contraindications like no allergy, if they don't have, or if they have good renal function, then I like to do as much as possible all initial patients study as a contrast enhanced CT. That is number one. Number two is, of course, follow up, as Dr. Chen highlighted, be done with all patients, and I use contrast CT very limited in children and in adolescent patients, obviously, and I don't overdo special procedures like three-phase. Three-phase CT, many centers do it as a routine if there is a liver pathology that is suspected. So I do that mainly for hepatocellular carcinomas, HCCs, or neuroendocrine tumors. Otherwise, I don't do that. So we are selective in that approach. But otherwise, I like to do a contrast enhanced CT in almost all patients because I have the confidence to report that. And more than my confidence, I strongly believe after the SPECT-CT is done with me, I don't want that patient again to go for a regional CT. So I want to give as much information as possible. That's how I approach.
I just wanted to go back to the parathyroid scan. In our department, the patients with known cases of chronic kidney disease, we have done initial imaging, we are seeing significant uptake in thyroid, and the patients bedridden, so shifting the patient. Those are the times where instead of doing multiple imaging, we can in the patient and we already know the serum creatinine levels are high. We try to delay the images, say 3 hours, or take it after 4 hours, depending on the uptake pattern. So as the doctor said, we always do at 7 minutes the 2-hour imaging. But then if you already have previous scan, parathyroid is negative, still PTH is high, we have an entity of rapidly washing out, then do a 1-hour imaging. Depending on that, do a SPECT-CT. And those patients with high serum creatinine values, try to delay the image instead of taking 2 hours as recommended, take a 3 hours of 4 hours so that we can have diagnostic accuracy of the.
If there is any thyroid nodule or multi-nodule, it's preferred to do this last phase delay.
Yeah, we always do an initial only those cases where the creatinine levels are higher side, and you are seeing some updates which may be adenoma because of PTH is high. Always try to delay the instead of calling the patient back within 2 hours, call 3 hours. And a SPECT-CT so that you can pause the information. Instead of calling the patient, it's 2 hours.
That one is for those who have high creatinine.
Yes.
What about those who have normal creatinine, but they have this thyroid?
1 hour delayed image. So 1 hour delayed image is for the patients with concomitant thyroid problems, and 4 hour delayed image for patients with chronic kidney disease. Very good question. Actually, first of all, clinically, we must understand as clinicians, parathyroid adenoma is a very uncommon disease. It's not a common disease. But parathyroid adenoma versus parathyroid carcinoma, there are no centigrade differences. But there are some points which may point towards the possibility of parathyroid carcinomas. Number one, parathyroid carcinomas are very large most of the time. So the size matters there, number one. Number two, the uptake will be significantly high. That is number two. Number three, so obviously it will be very much seen both in the initial and delayed scans. There is no washout, and even the initial image itself will look like a delayed image of the significant uptake. Number three, sometimes if we are lucky, we may show more than one spot of system-AB uptake like lymph nodal metastasis or a distant metastasis. Then you will think in terms of parathyroid carcinoma. Having told that, Please keep it in your mind. Brown tumors, severe hyperparathyroidism. The brown tumors also will show significant system EB uptake, especially, obviously, it is in bones. So if you see high system EB uptake in parathyroid carcinoma diagnosis, you will make if there are uptakes in lymph nodes, lungs, and skeletal. But if you see only in skeletal uptake, you have to be very careful. It can be simple hyperparathyroidism, brown tumors. It has to be kept in mind. So the answer is, it is not possible to differentiate a parathyroid carcinoma from parathyroid adenoma. But two important points: the parathormone may be very high in parathyroid carcinomas, number one. Number two, locally invasive. So it may be a large tumor. 3, significant retention. 4, if there are significant distant unsuspected metastases. Yes, quantitative, and this can be done, but basically you always will compare it with the thyroid bed uptake. If it is equal or more, that is how we look into that.
Any more questions? Ask question on the floor.
Which patients do you think are 4D CT better than the CT?
We were using 4D CT in patients where all nuclear medicine procedures have failed. The planar, the SPECT-CT, and the subtraction scan, everything is negative, but the PTH is more than 100 or more than 200. You are unable to exactly localize it. You will go for a 4D CT. But now, with the availability of choline PET-CT, I think even that will reduce. But there are many proponents, surgeons, who want to have 4D CT because it gives excellent anatomical location to them. That's where I like to use a CT of our equipment, 40 to 80 MA, even though it is a non-contrast CT. If you give anatomical localization, we can reduce it. But to the question, yes, 4D CT when nuclear scans and ultrasound fails to identify the pathology.
Okay, so with that, we would like to thank all the speakers.